Thank you very much for joining us on a lovely sunny Friday afternoon. We've got an excellent webinar for you this afternoon. The title is Speech and Communication Difficulties in Motor Neuron Disease from a Real Multidisciplinary Approach. So I'll go into a little bit of detail around the speakers in a minute. We just wanted to mention that actually our education that we provide is primarily for clinicians to support people with long-term neurological conditions. But I wanted to mention this one because this one is about you. This is about supporting you in your workplace. So do please have a look on our website. It has a lot of support and it's on demand, so you can complete it as and when you have time. I just wanted to say a really big thank you to our sponsor. The webinar has received sponsorship from Zambon UK. The first session in the webinar is designed and delivered by the MND Academy and sponsored by Zambon. The sponsor has had no input into the educational content or organisation of the session. The second session is a satellite symposium that is designed and delivered by Zambon. So just to introduce you to the speakers, we've had a last-minute change. We did have Dr. Pablo Garcia-Roitbeck, who unfortunately has been unable to join us today. So very last minute, and we're really appreciative. Dr. Claire Galtrey has kindly agreed to step in. She is a consultant neurologist working at St George's Hospital in London, and she is specialising in MND. And then also we have Molly Crehan, who is a highly specialist speech and language therapist for adult acute services, and Nicola Davis, who is a specialist speech and language therapist. They both work at Hillingdon Hospitals, NHS Foundation Trust. And also joining us today, which is really great, and thank you for taking the time, is Jennifer Bedford, who is Head of Information and Professional Development at the MND Association. So just to give you an idea of the timeline for the webinar, the initial part from MND Academy is around speech and communication in MND. We will have a 5-minute break and then hand over to Sophie, who will be talking us through dysphagia in MND. So just quickly to go through the aims, for which I'm sure you've already had a look. The kind of aims that we want to cover during this webinar is to provide an overview of how MND affects speech and communication, to introduce key strategies and the multidisciplinary approaches to managing communication challenges, and I guess show the complexities around that, and also to highlight the benefits of early intervention and assisted communication support. So it's my absolute pleasure to hand over to Claire, who is going to kick us off with an introduction to motor neuron disease. Thanks, Claire.
So yes, thank you for this. I'm very pleased to be joining even at short notice. So what I'm going to try and do, we've probably got quite a broad audience, but just give an overview to motor neuron disease, and I'll try and draw out at each point the particular issues around bulbar function, speech, swallowing, and communication. So this is probably, there's quite a number of individuals living with MND. Unfortunately, a number have now passed away. So there's a lot more awareness in general of MND now. But what it is probably a large group of conditions where the motor neurons that control motor function degenerate more quickly than the rest of the nervous system. And that affects anything that needs motor neuron and muscle function, which includes speech and swallowing. There's lots of mechanisms involved in this, that too many really a whole talk, but the crucial thing is that both a number of things, how I talk to the patients is a number of things need to happen in order for someone to get MND. Probably a couple of them are genetic background, and we'll touch on that later. And then things around inflammation and toxicity. And then generally we end up with TDP-43 deposition and unfortunately the degeneration of motor neurons. When we're thinking about the diagnosis and then looking at the subtypes, the up-to-date kind of criteria have been simplified in many ways to these Gold Coast criteria, agreed by a group of MND experts on the Gold Coast just before COVID. And to really split things out much more straightforwardly, with the old criteria, we were having people who unfortunately were dying of motor neuron disease with a diagnosis of possible or probable MND, which wasn't right. I find this much better clinically. You need a good history where you've got progressive motor impairment documented by repeated clinical assessment and previously normal function. And that's often something that's seen by community therapy teams, particularly speech and language therapists for swallowing problems. Then we need upper and lower motor neuron signs either in one body region. So if we come here, one body region might be an arm or a leg, but it could also be the speech and swallowing. So they're the big ones for me. The big three would be speech and swallowing, arms, and legs. And if you've got them in both, there's an allowance, low motor neuron function in both. It's not so relevant for bulbar. Focusing on today's discussion, about just over 30% of people present with bulbar symptoms, both lower and upper motor neuron as their presenting feature. But even of those who start with a problem in the arms and legs will go on later to get problems with speech and swallowing. I touch very briefly on this because I think it is relevant to communication. There is also a spectrum of cognitive involvement from full frontotemporal dementia to just some behavioral changes, which I think is always worth remembering if you're really struggling with communication, and to wonder if there's a cognitive component as well. So when we're staging clinically, this King staging is the one I like to use because it is quite straightforward and training is quite simple. If one of those regions are involved, so just arms, just legs, just swallowing, it's stage 1. Stage 2 is the most common time when people are diagnosed. So they've got an arm is weak now and they're swallowing, or swallowing first and now their hand's gone weak. Then your third region. And if you need any sort of supportive treatment, be that gastrostomy for swallowing or non-invasive ventilation, then it becomes a stage 4. And so we have ideas of how long survival is, and you can welcome to look at this later, but I think this is the bit that's key for this discussion is, unfortunately, if stage 1 is bulbar, then the median survival is unfortunately much less than if stage 1 has limb onset. So it is a very important group to think about. And that's borne out here looking at the stages. Kaplan-Meier curves basically just shows how long people live before they don't survive, and the staging is helpful there. Again, something I use clinically, I just wanted to share with you. And this, again, has come from the King's group, looking at their cohorts going back. And the things they find it's helpful, because people do ask, how long have I got to survive? And people need to know, they need to plan. And a few things came out. So basically, how long your diagnosis is delayed by. Now, that is in many ways can be seen as a reflection on the state of the NHS, but actually it means that it's a proxy for rate of progression. That's how I think of it. Your age, whether you're bulbar or limb onset, and whether or not you take riluzole are the ones that make a difference. The big thing to remember about these graphs, though, if you ever did want to use them either for yourself or with patients, is there's a 50% error margin on them. So, you know, if you pick someone who's fit 60 here, bulbar onset, and get somewhere just under 23 months, but you've got 50% either side, so it's not hugely helpful, but it's the best guide we have, I think. This one I was just going to share if anyone's working with people long-term in community teams, is using something called the ALS rating scale. It's a functional rating scale with questions about function. So for example, it's, you know, is your speech normal, intelligible with repeating, or, you know, whether you have communication, for example, you get 4 points. The very interesting thing about this is there's very good literature that any individual's rate of decline in their ALS-FRS rating scale holds in that individual's trajectory. So I've used this, for example, on a number of occasions to support a CHC application. So that's sort of quite a practical use to try and get people the timely support that they so often need. So just in case that's useful to anyone else. When we talk about caring for people with MND, it needs a full approach with everybody Neurologists are really a very small part. Respiratory is a big part. The nutrition teams with dietitian, nutrition nurses and gastroenterologists. Ongoing speech and language are particularly important in bulbar symptoms, but with a full MDT, with eventual advanced care planning and an end-of-life support as well. So what I tend to do is the stuff in the clinic, the testing, the diagnosis, medications, but there's a lot else that needs to happen. And this study, I think, is always very nice, just to demonstrate that a multidisciplinary clinic is helpful. And this is in Ireland, and they have Northern and mainland Ireland, Irish Republic. And if they have a specialised or no specialised clinic, it doesn't make it, what makes the difference is the coordination of the care together, getting the right things happening at the right time. So a lot of the treatments we do are symptomatic and supportive. There is only one licensed drug, which is Riluzole, which has been shown to make about a 10% survival improvement. But again, just to draw out the division there between the bulbar onset and the limb onset, unfortunately, there is probably still some benefit there. In terms of supportive care, non-invasive ventilation to support breathing has been shown overall to be helpful, but again, splitting our groups out with people with severe bulbar impairment, it's often less helpful. I think often quite difficult for people to tolerate with secretions and laryngospasm. Again, just in case anyone's not using the My Breathing, My MND website, developed with people living with and caring for people with MND, with the Sheffield team, is very helpful to support discussions with people at this point in their care. Tracheostomy, again, is definitely one of those that's a whole talk in itself, but I think something we're seeing slightly more of and can support the right people, but needs a lot of MDT support. Nutrition is crucial, and we know that survival is affected if people have lost more than 10% of their body weight, and that's when supporting people to not lose weight by offering insertion of gastrostomy can be helpful. This is the PROGAS study, which looked at this about when to insert a gastrostomy. And again, if you haven't already, using the MyTube MyMND website is very helpful, so people can review that discussion with some support when needed. Saliva management, I think, for me, is probably something that causes most distress to people. Is difficult. Excess secretions. It's quite distressing, and from skin care to social anxiety to a lot of problems. So there's a number of different medications that can help. A number of which I think all of us have had significant supply problems with in the last 12 months. So hyoscine patches tends to be first line. Atropine drops can be used sublingually, and glycopyrronium. I often go to glycopyrronium first if there was cognitive involvement, because certainly hyoscine can cause confusion. I've put here that unfortunately the resolution is not very good, but quite a nice flow chart of if the saliva is thick, thinking about carbocysteine and hydration. I've certainly seen that if people have not had a gastrostomy yet and are quite dehydrated, then helping with hydration first is helpful, using pineapple juice and other methods. Then the thin secretions, as we've talked about, and assessing the response. Botox can be helpful, but is not easy to get, particularly from home for large numbers of people. And some of the oncology services will help with radiotherapy. So if Botox has been helpful but very short-lived, can last for up to 18 months. So I'm just going to touch on a couple of other topics, because I know we need to get on to the main event, that are current and new that you might not have come about. And the first of those is genetic testing in MND. So very roughly, around 10% of people, even without a family history of MND, there's a genetic component. And I come back to what I spoke about at the beginning. If we think that maybe 6 things have to happen to someone in order for MND to become clinically active, 1 or 2 of those might be a genetic background. So this isn't like if you've got the gene, you'll definitely get it, but it certainly adds to the risk. And why it's come into the fore is because there are an increasing number of therapies antisense oligonucleotide therapies that can be used for specific mutations. And so now we would generally offer people testing. I have to say the one we have treatment for at the moment is the SOD1 mutation here, which is quite rare, and bulbar onset in SOD1 is very rare. I can probably only think of I've ever seen one case. But still, the treatments, as we can see in the next slide with this intrathecal, so given through a lumbar puncture drug tofersen, does show quite a lot of benefit in terms of survival, particularly in the open label extension. So a lot of people understandably want to explore that option. So we're doing a lot more genetic testing. And the other thing is about clinical trials. People often ask, and I know they ask us in clinic, but I also know from colleagues in the region, when the community teams are spending a lot of time with people, they ask them as well. So just so you've got some flavour of what's going on, I probably should have put on here, there's both the MNDA have an excellent website summarising currently recruited clinical trials, and there is also an MND clinical studies group, which keeps an up-to-date list of recruiting trials in the country so people can access their options. The MNDA is definitely a good place to start there. Some trials we have been recruiting to at St George's recently, MND Smart. So this is set up. So here is Pablo, who isn't here, recruiting his first MND Smart patient. And then the main thing that's exciting about MND Smart is that it's set up as a platform. So once we've set up all the ethics and the logistics of the trial, it continues running, the placebo arm runs, and then they bring in drugs that are interesting from a preclinical basis without us having to redo all the infrastructure. So they've tried memantidine and trazodone, which were safe, but did not, unfortunately, have efficacy. And that's recently published in The Lancet, and are hoping to start some new arms, hopefully in the next few months. I was just going to mention, particularly to this group, Optical. So this, again, is come from the Sheffield group, of the idea that we think the motor neurons are really struggling, probably from a mitochondrial energy point of view, and ensuring excellent nutrition may help those motor neurons who are struggling to survive. And essentially in this Optical's trial, it is a randomized trial, 2-to-1 randomization to additional, essentially a dietitian, quite a high food fast, high calorie, aiming actually surprisingly for a BMI of 30, it's quite hard to achieve. Trials. We do it with one of our extremely experienced dietitians. So certainly an option if people don't want to think about drug trials, currently recruiting in a number of sites. And then trials about to open. This is a phase 2 trial, starting to think more about the mechanisms. So we know genetic things cause people to cause the motor neurons to start degenerating, but probably how the immune system reacts to those degenerating neurons may affect the speed of progression. And there's a number of different trials, of which I've just shown you one, where affecting that process and decreasing the immune system's reaction may slow the progression. So that's an exciting area as well. So in summary, bulbar symptoms are often prominent at onset, which worsens survival, unfortunately for that group, but can also then affect people with limb onset later. And certainly working very closely across our multidisciplinary teams is definitely benefits patients and may improve survival. Genetic testing is becoming more important, mainly so people can access tofersen in clinical trials, and other clinical trials, non-genetic, are increasingly available. Thank you very much.
Thank you, Claire. Wow, that was a whistle stop through a lot of information. That was really appreciated. Yeah, thank you for that. I think we're going to save questions to the end, just so we can hear all of the speakers. So let me hand over to you, Molly and Licky.
Hello, hi. Hugh is going to kindly share our slides, so apologies whilst we direct him through those. But I'm Molly. I'm a acute speech and language therapist at Hillingdon Hospital.
And I'm Nikki. I'm a speech and language therapist at Hillingdon Hospital who works in neuro rehab, and I've also worked in the community with motor neuron patients too.
Great. So today we'll just quickly cover what the SLT and MDT role do, as Claire sort of covered the MDT role as well, but in the assessment and management of communication difficulties, what we do and why early intervention is important, assistive communication options and how to access them, and if we hopefully have some time, we'll cover a case study as well. So we're going to take this our talk through a bit of a timeline. That's how we felt was best way to show how SLT, speech and language therapy, have a role with patients with MND. So the first things is referral. So referral to SLT, it's very common actually that speech and language therapy are one of the first in the MDT to sort of notice some of these changes in patients, particularly with the bulbar condition. So usually they're referred to us for swallowing changes or speech changes of an unknown origin. So they don't quite have a diagnosis yet. We're assuming in this timeline the patient hasn't had a diagnosis. So we will prioritise and triage the patients that come through to us. Referral might be something like patients got slurred speech, and we'll kind of clerk them in and gather a bit of the background, what their previous medical history is, their case history, their social history, and where they live and who they live with and things. And as per the NICE guidelines, which our clinical practices very largely we work against, SLT assessment and AAC provision should be carried out very early intervention, really. So there shouldn't be a delay in that. And yeah, that would be sort of a cause for concern if they haven't been flagged to speech therapy yet. And the MNDA also recommend that patients should be seen within 4 weeks of their symptom onset by a speech and language therapist. So first of all, we'll do an assessment. This is very much, I work in the acute service, so in the hospital, and this is very much where my role, what happens in my role is it will be that case history taking. So speaking to the patient or maybe their family, close family, if they have family or friends, and sort of talk a little bit about symptom onset, what are the symptoms, and if that's been gradual, which is mostly the case, rather than sort of sudden onset. We'll need to do an oromotor exam looking at cranial nerves 5, 7, 9, 10 and 12 predominantly for speech therapy. Key things we look at, we'll go into this a little bit more, is tongue fasciculations is a big indicator of MND. So that's holding their mouth open, but their tongue at rest. So tongue mustn't be protruded at that point. It must be at rest, and we'd look for a minimum of 30 seconds. We'll be looking at lingual control and strength and lingual muscular wastage. And whilst this also comes into play with dysphagia, which we won't talk about today because we're aware that you've got a whole talk on that with Sophie, but this also will help us identify any causes and weakness for the speech. So why there might be some imprecise articulation. So slurred speech can often be because of the sort of reduced articulatory strength. So poor tongue control and poor tongue strength. We'll do some oral trials usually, which involves feeding the patient. There's a range of things we might try, but for example, giving them a drink of water, maybe a bit of yogurt, and assessing what the swallow looks like. Again, Sophie, I'm sure we'll go into this, so I won't cover that today. And communication, will be assessing their language and cognition, any sort of behavioural changes, their ability to follow commands and sort of understanding language. Speech, is it slurred? Are there resonance changes and might be indicative of some sort of soft palate changes? And their voice quality as well. So it might be breathy or weak. And if there's any sort of respiratory compromise, we might see that actually they've got reduced phonatory strength. So their speech might be quite quiet, and also hypernasal resonance as well. One thing we'll do once we start seeing sort of concerns, we would definitely refer to a neurologist very early for an early assessment by them. So that would be something we'd be doing very quickly and asking the leading team to initiate if there are concerns with motor neuron involvement. So one thing speech and language therapy assists in doing is signposting, and actually it needs to be around patient readiness. So sometimes once someone's we're assuming now this patient's had their diagnosis, so we're taking you through quite a quick timeline, but let's imagine the neurologist have seen and patient has gone for those nerve conduction studies and things that Claire covered, and the patient has a diagnosis. We need to kind of look at the speech and language therapy readiness in terms of they've often had quite a heavy diagnosis, and that can come with a cycle of grief, and they also need to be acutely stable as well, really, for us to intervene and come in with some of our therapy ideas or intervention. So we will also provide written information and leaflets, and often kind of just introduce ourselves and about our role and what we can offer, and sort of very much be guided by the patient on when they're sort of ready to explore some of those options. But we will always signpost them to the MDA Association and get them to register for that as well. So onward referrals is key in our early assessment and intervention. So as I said already, the neurologist, and this kind of timeline is not This happens sort of simultaneously as well. So it's difficult to kind of say step by step what we do, but this is kind of all happening simultaneously. So we'll refer to neurology, as I said, and then specialist services, which Nikki will cover in a minute, about sort of communication aids that we can look into. Nutrition and dietitians will come into play in terms of their eating and drinking recommendations and support with their nutrition. Palliative care, a little bit, perhaps as soon as we really know about an MND diagnosis, we would be referring to palliative care for their advice and guidance, and specialist neuro and MND nurses as well, which we're lucky to have a couple of specialist neuro nurses here in the hospital, so we'd always be referring to those. And I will hand over to Nikki.
Thanks. So I'm going to talk about a timeline of kind of the more communication and AAC side. So as soon as that patient's got the diagnosis and we're assuming they've got the diagnosis, we want to discuss voice banking as early on as possible, ideally before voice changes, although admittedly sometimes that is the reason that they're referred to us. We can apply for funding for voice banking website, voice banking via the website, or the MNDA association kindly funds one predictable app across on one device. So I'll go a bit more into that. We use software to bank the voice, and we set up with multiple alternative communication devices. So with motor neuron disease, this is super important because it really helps facilitate those discussions around longer term feeding decisions, which, as Claire's already mentioned, is a really important part of the patient journey and can really impact quality of life and survival rate as well. As the condition progresses and people might start to lose the control of their hands, they might need more specialist AAC devices. So we're looking at things like eye gaze or head switches. And every region in the UK has their own kind of specialist AAC service, and that tends to be run by really, really, really smart occupational therapists. So it can really help patients advocate for themselves. So these are a couple of examples. So you've got a cappella, which is really good for banking the voice exactly. So that's before you've seen any change. Speak Unique, which has a voice repair service. So if a patient's got slurred speech or is a bit dysarthric, they can use that one. And then there's a predictable app, which is kind of a bit like predictive text on your phone in that it learns the sort of things you say. So it gets less fatiguing using that to type things out, especially if you're using a hands or eye gaze. Obviously, fatigability is a big factor in motor neuron disease. It's also really important we set up communication booklets in case the battery runs out, basically, on our high-tech AAC, or something happens or someone drops it. They're quite breakable. And when it comes to the inpatient settings, we sometimes use things called an e-tran, which is, you can see them holding up that in the corner. The patient, if they only have eye gaze, can spell out different words. I think one of the things you need to be really mindful of is that if cognition is a factor, as Claire mentioned, with some patients might present with full-on frontotemporal dementia, they might not have the working memory to then be able to keep track of what they're spelling with an e-tran. So sometimes we can replace that with pictures or stick things on. And it's quite hard for you as a communication partner keeping track of what they're spelling. We also, one thing I've not mentioned is refer to environmental services. So that's run by the council, and they can do stuff like light switches, TV remotes, adapting their house a bit more, but that's not so much speech and language role. So this is a bit of a timeline of our role with a patient. So we assist as indicated. Because of the cognitive changes, we use picture support to help facilitate mental capacity assessments. That just makes it a bit less fatiguing for the patient as well. We voice bank as quickly as possible, ideally kind of within a week of someone deciding that they want to voice bank. We want to get that done as quickly as possible before the voice changes. We don't tend to do rehab therapy with motor neuron disease patients because it's a bit of a fine line. So research has shown that moderate endurance exercise can slow functional decline. In EMST particularly, this is an EMST study. However, high intensity training can be detrimental, so that can actually be contraindicated. So our role is more about maximising quality of life, advocacy, and really sort of looking at that holistic way. The MND best practice guidelines for health professionals say ensure the patient's opportunity to discuss advanced care wishes. So opportunity might mean facilitating that with an AAC, pictorial support, and that really is our role there. We've got references at the end of these as well, if anyone wants to look at the guidelines. So we help facilitate the MDT discussion as well. So we're involved in pretty much all case conferences just to, again, help facilitate advocacy and patient communicating. MDT meetings, which might be around other things. So, for example, PEG, advanced feeding, advanced wills, facilitating access to information, prophylactic PEG, and then we quite often work alongside palliative care for end-of-life discussions as well. So whereas these aren't directly related to our role, we're actually kind of involved in everything because we help them advocate for themselves and everything, and really want to try and preserve their quality of life. Okay. 5 minutes left. We're now onto the case studies.
Yes, so this is a real case study from us. We have changed the initials for the sake of confidentiality, but for argument's sake, patient is AB. He's 73 years old, male. You can see his previous medical history there and medications. He didn't have any baseline coming in. No previous speech and language therapy input. He lives alone, denies smoking and drinking, is independent, no close family, unfortunately. His neighbour helps him with the shopping. So he came in with a fall and a long lie, and then likely AKI with metabolic acidosis, the sort of delirium and sepsis, pressure sores, and some self-neglect. He was found by the police, sort of in his urine and feces, quite unkempt at property. Neighbour was concerned that they hadn't seen him for a few days and they called the police. So that was sort of how he was found. There was no respiratory distress on the medical entries, reduced airway entry on chest auscultation, and they were unable to fully assess cranial nerve examination. But he did have pressure sores. He was referred to us for coughing with his cup of tea, observed by the nurses on the ward. So again, Sophie will talk a little bit more, I'm sure, about this in a bit. He was losing zero and his infection markers were within normal range. There's nothing sort of too acute that was concerning at this stage. His chest x-ray, no consolidation. He did present with full alertness and slurred speech, and there was nothing on his CT head but an old basal ganglia lacuna infarct. So hypothesis after we were gathering some information is that what do we need to do now? So there was no sort of clear reason maybe for his fall initially, suggested brain imaging to sort of rule out an acquired brain injury or a stroke, and there was sort of nothing identified initially on the CT head. Cranial nerve assessment and full swallow assessment, SALT assessment was indicated because of the slurred speech and the coughing of the tea. Onward referrals to other care professionals sort of had in the back of my mind might be indicated, liaison with next of kin for baseline or closest friend or this chappie unfortunately didn't have family nearby or any close relatives, but the kind of closest person to him. Liaison with dietitians for artificial feeding provisions was in on my hypothesis, and also to refer to the neurologist.
So, swapping again. So when it came to taking the case history, we took the case history from this gentleman's neighbour because he was the closest person to him. So I've just picked out a couple of interesting phrases. I'm not going to read everything out. I'm just going to pick out the interesting ones. So we've got things like he was trying to get him to read loudly, so that shows his voice is declining in volume. His neighbour reported everything had been declining for about 3 years. Apparently he was finding it difficult to respond because he'd forget words and say things incorrectly, so that could show the cognitive element of the communication as well. He said he used to be working in his garden and enjoyed gardening but stopped because of dizziness, so that could be vestibular issues or something more prognuria going on underneath there. And he reported that he's slowing down day by day and also eating mainly cold, softer foods, which is interesting because it could show a bit of a baseline difficulty with swallowing. But again, Sophie will go on to that a little bit more.
So completed a cranial nerve assessment, and again, similar to Nikki, I won't sort of go into everything, but we're looking at jaw strength, and he's showed sort of, again, I don't want to talk too much about swallow, so I'm thinking about how I can keep some of this out. But we're looking at jaw strength, good mouth opening, but he was unable to sustain, which showed a little bit of fatigue and strength. There was moderately decreased palatal elevation on phonation. He was dysarthric. So we know that there's bulbar element there with his speech changes. There was tongue deviation to left and protrusion. We didn't actually see any, we saw tongue fasciculations at rest. I think actually not on initial assessment, but we did on a follow-up cranial nerve exam. I think when he first sort of came in, there was difficulty assessing patient because of his sort of cognitive status and alertness at the time. But at a follow-up cranial nerve assessment, there was tongue fasciculations as well. Had poor lip seal as well, showing weakness of the facial muscles. And I'm just trying not to comment too much on swallow, but we can see that there are multiple deficits across the cranial nerves that we assessed that were impacting both his speech and his swallow. So it's definitely some bulbar involvement.
So on top of that, we had whole body observations. So the things that Molly's just kindly commented on is going to affect his speech and his swallowing and his voice. So he had quite a hyponasal vocal tone as well because of that uvula, but he also had, the dysarthria. He wasn't able to feed himself. He was kind of jerking his legs in the session. And he was leaning to one side. So actually the asymmetry I didn't think was particularly typical, but obviously people can kind of present in a lot of different ways. So the diagnosis was suspected progressive bulbar palsy. So Claire's already kind of gone through this, but affects lower motor neurons supplied by cranial nerves, and flaccid dysarthria and dysphagia are predominant signs with this chap. So I'm going to whiz through this. Essentially, following the confirmed MND diagnosis, he was referred to MNDA, given an iPad and a high-tech AAC. So we chose an iPad because he was going to then be ready for eye gaze if needs be. He was only about 5 to 10% intelligible in speech at that point, unfortunately. So he was unable to kind of use Predictable, the app, that much. And we weren't able to bank his voice by this point. And because of his cognition, he got quite frustrated with that AAC. So we actually ended up using a communication booklet and old-fashioned kind of picture support in the end, nothing too fancy. SLT, medics, palliative, DT and MDT all collectively educated the patient next of kin on his choices. This actually went back and forth for quite a long time because we wanted to give him the chance to make the decision. And the rest of this is quite swallow heavy, so I'm just going to skip through that. But essentially, the outcome was that we helped facilitate these discussions, and he ended up actually choosing to have a PEG, I think it was a PEG, PEG insertion, and continue to have taste for pleasure. And he, by the end of it, acknowledged and managed to minimise the risk. So.
Yeah, we'll just cover this last bit then on essentially we were involved in assessing mental capacity assessment and making sure that was done, information was provided in an accessible format for him, and advised a neuropalliative referral as well. He did demonstrate full capacity to make decisions by retaining, retelling and weighing up information before making informed decision. And he got the outcome that he wanted, which was sort of to go via his gastrostomy, but also have some eating and drinking trials for quality of life alongside that. But just the main sort of thing we wanted to focus on there was how we were heavily involved in all of those kind of discussions along his timeline. We were there to facilitate, ensure that the MDT were aware of his communication needs, and that he had his AAC with him, and that he had that information presented in an accessible format and the opportunity to express his own wishes. So that's a whistle-stop tour through communication and speech with MND.
Yeah, that's amazing. Thank you both so much, and really appreciated all the content and information. And I think it is a huge amount of it's a huge topic to try and cover in such a small amount of time. So really appreciate it. Thank you. I just wanted to come to you, Jen. Actually, I know there's been lots of mention of the support from the MND Association, and I just wanted to open it up to a kind of a comment or your kind of thoughts in your role, the kind of importance of the clinicians that are on the call referring patients early, and especially in the kind of speech, communication, swallowing kind of difficulties.
Yeah, I mean, there's lots that's come out of this discussion. So there's a few things I just wanted to touch on, really, if that's useful to people. I've also got some links I could put in the chat if that's helpful too. One of the things I thought about was our red flags tool, which helps with the diagnosis of MND right at the beginning there, separates it into limbs, cognition, respiratory and bulbar features, which aids that kind of referral through to neurology, which is what we see at the association as the key thing to get that diagnosis of MND, to get things moving and going through. So I think that's the first thing to say, is that we absolutely see that's where it all starts, making sure that we know what we're dealing with. And then obviously the MDT kicks in, and you can see exactly what Molly and Nicky have talked about. I think when you have an MDT, what you have is all eyes on the patient, really, so that you can start, so if someone sees something happening, they can refer across to colleagues. Absolutely agree with the fact that you need to voice bank very early on. Message banking is really important for this patient group as well, so make sure their wishes can be respected. And I think communication is important, as we do all at the association, so people can be not only an informed patient, but they can take part in the decisions as well. So making sure that we know how patients can communicate, be that with a yes or a no answer. It's really key to them being feeling they've had good care. With regards to the association, there's lots of patient literature that you can refer people to, and often that's a help to professionals in that space. We've certainly got a lot of information about communication. We can also help with, I think, as was touched on, help with getting the actual equipment that's needed and making sure you get that in a timely way. So there's that kind of thing we can help with as well. The gentlemen also seem to have, in the case study, seem to have certain issues with other things going on, living alone. We have a living alone booklet that could be useful to invoke here. But we also have lots of support that we can give through our Connect service, so we can connect people up with other things, help them with benefits, that kind of stuff. So I think our MND Connect service, I'm going to say it very slowly so people can get it down if they want, is 0808 802 6262, and that's your port into all of the services at the MND Association. I also just wanted to mention that if people are particularly interested in communication, and as Ruth has said, it's a difficult subject to cover in 45 minutes. And I think Molly and Nicky will nod their heads quite a lot when I say that. But we have at the association got a communication online workshop that's going to run, and that's about effective management of communication difficulties. It's going to cover things like voice banking, message banking, how cognition affects communication. And I will put a link in the chat to that. So if people want to sign up for that, you're absolutely more than welcome to come. And just on that note as well, as the association, we can support you as health and social care professionals. We have a community of practice, which includes an online forum, so people have 24/7 support from peers. They can post questions if they've got something they can't answer themselves. We've got an accredited by the RCP education programme. Please take a look at that. There's a wide range of webinars on a variety of topics that have been recorded from the past, and we've got a whole programme of them coming up this year. And we also have information knowledge exchanges through the community of practice, and a CPD fund if people do become members of the community of practice. So we really do want to support you as professionals. And I guess the other thing I should say as well, the gentleman from the case study, we do have volunteers as well that can offer support where people are living alone. So we do have association visitors, so that people can get that kind of support. But I'm happy to answer any questions if anyone has anything.
Thank you, Jen. Thank you so much for that. We can put the link on the website actually underneath where the video sits. Claire, I wanted to come to you just kind of as we draw it to a close, and just for your response to that case study. It's incredibly complex. Molly and Nicky did an amazing job presenting something that has obviously been, obviously over a period of time and so many things going on, so many discussions. And in a way, I think part of the issue is having the discussions when someone's deteriorating quite quickly. They have to happen fast. So I don't know, Claire, if you want to comment from your point of view as a neurologist.
I mean, I think there's so many things you could say, isn't there? But and it's almost like you need a red flags tool, like the MNDA have, even within the hospitals as well. And both myself and Dr. Garcia do run the MND clinic, but we also do acute neurology as well. And so we have quite a lot of reflection on this. And I was reflecting on a case only this week. When someone comes to the MND clinic, it's usually quite obvious they've got MND because they've seen several neurologists beforehand. When you see them acutely, it's not. and working together is always key. And you need to work together with a number of different people. You need to work together with the person who's affected. You need to make sure they've got time to give their story. So often, particularly on acute medical admissions now, there's no time. Are they well? Are their bloods okay? And I think it sounds like here it was actually the therapy team that took that time and made that report. So that was very, very valuable. But collateral history, there's really very little substitute for saying, I'm quite worried about you. Can I phone your daughter and try and find out what's actually been going on? Can I phone your GP? Whatever it is that you need to do. So I think that has often been what's needed. And then, I mean, the MND are a huge champion of having these kind of care coordinators, both as someone, it's like a point of contact because you share expertise and you grow and learn. I think I said to you in the pre-chat, didn't I, Ruth, before this, if one of our regional speech and language therapists sends me an email and says, Claire, I think this person's probably got motor neurone disease, I never ignore that email because they're almost always right. And the same accounts for the ward therapists. So yeah, I think work together, listen, and make sure you get your collateral histories to try and get people to the right place at the right time, I think. But it's not easy.
Yeah.
As I said, nearly got myself in a mess only this week. You've got to be in the right frame of mind, and the MND clinic's the easiest place to be in the right frame of mind. Out on the wards, in the acute medical unit, ED, you've got to get the cognitive bias right and just always think.
Yeah. Yeah, thank you, Claire. We could talk for a long time. I think we need a
Good,
part
yeah.
two. I think we'll have to come back for part two so we can have more of a discussion. But just before I hand over to Sophie, I wanted to say a really big thank you to Jen, Molly, Nikki, and Claire for joining us for this part of the webinar. I think we'll probably have about 30 seconds to a minute, Sophie, before we hand over to you. But yeah, as we close down this part of the webinar, thank you for your input. Thank you for bringing such a complex case study and for sharing your knowledge and experience in this area.